Well, it's wonderful to have you here. And this program is on stopping the Wall Street takeover of traditional Medicare. I'm Marcia Brown, chair of the State Tax and Economy Committee. We plan programs on ways to obtain fair, adequate, and sustainable tax system and economy. We are sponsoring this program with the First Hill unit of the League of Women Voters. Adele Reynolds is representing them, and she's been president of the First Hill unit for many years too. Adele?
Okay. Just to refresh your minds, the League of Women Voters is firmly nonpartisan and neither supports nor opposes candidates for office. At the same time, it is political and advocates on selected policy issues after careful consideration by its membership. And they have a strong position on healthcare, supporting healthcare for all with a single payer. So that is what they are working for. We're very interested in this new situation, which we're going to learn about today. And Marcia, you're going to introduce our speakers, are you not?
I am. I just want to say, why did we bring this program up? Well, we've been getting many phone calls on changing our Medicare Advantage plan. And then there have been emails and TV ads. And just before I came on today, there was a big email from a organization trying to get us to choose them, the ABBA, I think it's the name of it. They want people to join their Medicare Advantage plan. All right, should we do that? That's what got me involved in this. And I saw the bulletins from the Healthcare for All and then PSARA, and it's amazing how many bulletins PSARA has put out on privatizing Medicare. So today we're going to have the PSARA officers, Karen Richter and Robbie Stern, and they will present their positions. I just want to tell you a little bit about them. I think it makes it more interesting for us. Karen worked for over 30 years in planning and development of public transportation systems, including non-motorized transportation and public transportation. She's lived in a number of cities, Tucson, Chicago, and 28 years in Seattle. In addition to her advocacy as co-president of PSARA, Karen is on the board of the 34th District Democrats and volunteers as an environmental educator with Seattle Aquarium. She's also a founding member of a Chicago chapter of the Women's Transportation Seminar, which helps women get started in the transportation field. Karen retired early to become her mother's caregiver and learned firsthand the importance of Social Security, the limitations of Medicare, and the necessity of pensions and long-term care coverage, and the need for everyone to have a dignified and secure retirement. Robbie Stern retired from the staff of Washington State Labor Council in 2008. He has been an active member of PSARA, serving as president for 9 years. He presently serves as the president of the PSARA Education Fund, chairs the Social Security Works Washington Coalition, and is active in PSARA's fundraising, RAGE, and the Climate Justice Committee. Now we're going to hear from them on stopping the Wall Street takeover of traditional Medicare.
So thank you, Marcia. That's very kind. We are glad to be here. For those of you that are new to PSARA, that's the Puget Sound Advocates for Retirement Action. We work across generations for social justice, economic security, a dignified retirement and a healthy planet for all of us. We advocate to preserve and expand Social Security, Medicare, and Medicaid. And that's why Robbie and I are here today to talk about a Trump-era scheme to totally privatize Medicare. So today we're not going to talk about Medicare Advantage, which is part of Medicare, and that is privatized Medicare. But we're here today to talk about traditional Medicare and what's happening in that space. So the plan to privatize traditional Medicare was through a pilot program that's called direct contracting. And it was started in 2019 through an agency called the Center for Medicare and Medicaid Innovation, or CMMI. And the Trump administration used this approach to use a pilot program to avoid formal rulemaking. In other words, there was no public input, no public scrutiny, and importantly, there's no congressional oversight. So this was just considered a pilot program. So we have a lot of issues with that. So the direct contracting pilot project has now continued during the Biden administration and enhanced control of traditional Medicare's healthcare to a third-party middleman. And those are called direct contracting entities. There's a lot of acronyms. I'll try not to use too many of them, or DCEs. So these include firms that are controlled by large commercial insurers, for-profit hospitals. It can be a private equity investor. It can be a hedge fund. It's often entities that we feel have no meaningful medical expertise. They are now paid a fee per patient to manage the healthcare of Medicare beneficiaries and traditional Medicare. And they can retain up to about maybe 25 to 40% of the fees that Medicare pays them per person to cover their administrative costs. And so this gives the DCEs the incentive to cut costs on patient care. And they do that by denying procedures, delaying care. They do something called upcoding to make a patient seem sicker than they are. And they do all this in order to receive higher medical fees and other ways to pocket more money, essentially. So this is a much different process as compared to the traditional Medicare, which pays about a 1.5% administrative fee. And why is that? Because there's no middleman. It's in a different way of doing it. So under the Trump administration, the agency issued a waiver, for instance, that exempts the DCEs from the anti-kickback rules that normally prohibit doctors from entering their patients in for-profit plans. So as a result, a doctor that's been bought out by one of these Wall Street firms, for instance, can now be compensated for involuntarily entering their patients into a DCE program. So how does a DCE make a profit? So here's some examples. So as far as a DCE might be concerned, 3 physical therapy sessions might be all that's considered medical necessary after a patient receives a hip replacement, for instance. But they do that even though more may be needed and as prescribed by a doctor, but they stop it at 3, even though a doctor may say there's 6 that are necessary. Or DCA may be a plain old, think that maybe a plain old X-ray will do, even though a doctor's prescribed an MRI. So the DCE can then pocket the difference in those costs. So you probably want to know what's being done to stop this program. So last January, Representative Jayapal sent a letter to that was signed by more than 50 members of Congress to Health and Human Services Secretary PSARA, demanding that this direct contracting program be terminated. In addition, there's an organization called the Physicians for National Health Program, you might know of. They provided testimony to Congress and submitted a letter to Secretary PSARA that was signed by more than 13 physicians demanding its termination, and other organizations around the country did the same. So the pressure worked, and Secretary PSARA announced that the direct contracting program would be terminated this December on the 31st. So we felt that should have been a celebration.
Sounds good.
Yeah, sounds good, right? But instead, the Trump pilot, this DCE program, was immediately rebranded and called ACO REACH. Now, that's another acronym. Excuse me. It's called, that means the Accountable Care Organization, Realizing Equity, Access, and Community Health. Really a great sounding program, right? And then they turned around and said that would begin January 1st, 2023, immediately after the DCE program was terminated. So a lot of health advocates around the country have looked at both programs, at the direct contracting and the renamed or rebranded ACO REACH models, and they see very little difference between them. The pilot projects are continuing to allow third-party entities to wedge themselves between patients and their healthcare providers, and to draw down on the Medicare trust fund and continue to make profits. Patients will continue to be swept into ACO REACH without their knowledge or consent. And payments to the ACO REACH entities will continue to be a set amount per patient and not per service as with traditional Medicare. Again, this gives them the incentive to restrict services and keep the remaining Medicare payments for their own profit and as reserves. So one thing we wanted to point out to you is that by 2028, the annual Medicare spending is projected to be about $1.6 trillion per year, which gives Wall Street a major motivation to buy up hospitals, physicians' practices, and other healthcare organizations. And you may know that very recently we learned that the Polyclinic right here in Seattle was bought by Optum, and Optum is owned by United Healthcare, which is probably the largest, it is the largest insurer in our country. It may be the largest healthcare insurer in the world. And you may have read in the paper that Amazon announced it wants to buy First Medical, which owns IORA. So what could go wrong with Amazon dictating our healthcare? So Medicare beneficiaries choose traditional Medicare because they don't want, or we don't want, a third party impacting the decisions that are made by our doctors and ourselves. And the DCE program and the ACO REACH program violates that choice that millions of Medicare beneficiaries have made. So PSARA is asking organizations in our state to pass resolutions and to sign on the letters that we have on our website that go to our state senators and congressional delegations, and to Secretary of Health and Human Services, Secretary PSARA, requesting that this program, this ACO REACH program, be terminated. This summer, for instance, we worked with the State Democratic Party and with the Washington State Labor Council, who each passed resolutions demanding the end of this program. We now have about 130 organizations that have joined our campaign, and we have about 1,000 individuals that have signed on to our letters as well. So we're working with national organizations also to tell President Biden to end this program on his watch, because we want a choice in our healthcare. So if you belong or know of an organization that would like to join our campaign, we'd love to have you. Just go to our website, PSARA.org, and let us know. And now I'm going to turn this over to Robbie, because I'm sure I've missed a few points that he might like to make. Robbie?
Well, I think you did a great job. I think you did a great job, Karen. The only thing I would add is I don't know how many of you have saw the Seattle Times or TNT or Bellingham Herald or Everett Herald on Labor Day, but we ran this ad of our Medicare, full page ad, and asked people to contact our two US senators. Oh, someone else is holding it up. Thank you. Ask people to contact your representative, except you all live in Representative Jayapal's district. So you would only
Right.
have to make 2 phone calls. You could call Representative Jayapal and say, thank you for
Yeah.
being on the side of seniors rather than Wall Street and the large insurers. But you only need to call Senator Murray and Senator Cantwell, and the message that we want you to say to them is in the ad, but it says, you know, basically that we want them to stop the privatization of traditional Medicare and terminate ACO REACH. Which side are you on? The side of Medicare beneficiaries or on the side of Wall Street and corporations? So that's what we're at, the action we're asking people to do. We're in the process, just so our elected congressional delegation, and we have 2 representatives that have stepped out on this already and have joined us in this, and that's Representative Jayapal and Representative Adam Smith.
Good.
The others have not yet. And we're going to continue to put the pressure on. We are now in the process of determining whether, and this is, you know, PSARA is not like this rich organization. I want to assure you, our membership is $20 a year, but we think that this is so important. I mean, this is fundamental to people that care about the ability of people, seniors and disabled people, to live with dignity and respect and have trust in their healthcare system. Those of us that choose traditional Medicare, and I'm one of them. And there are drawbacks. I mean, you know, the thing that Medicare Advantage sells is that they're less expensive than traditional Medicare. Because when you get traditional Medicare, as those of you who are on it know, you pretty much have to buy Medigap insurance.
Yes.
And that can be pricey. And we're working on trying to make Medicare a richer package. And if you all remember, in the proposed Build Back Better bill that never quite made it out, there was the inclusion there of a hearing as part of that within Medicare. But that unfortunately did not get passed. But I guess our point is, what we need to do is improve traditional Medicare to cover vision,
Yes.
hearing, and dental. That's what we need to do. We don't need to allow the likes of Amazon and private equity firms in as, you know, third parties in our traditional Medicare program. Ultimately, we're going to have to take on Medicare Advantage as well, because there are some bad actors in Medicare Advantage. We know that. We know the report of the Inspector General was that approximately 10% of denials of care by Medicare Advantage were improper, and we intend to take that on. But right now, we got to stop these private for-profit entities, whether it's Wall Street or Amazon or United Healthcare, from taking profit out of traditional Medicare, money that we paid into the Medicare Trust Fund our entire working lives. And I'll be darned if I want to see that money go into the pockets of the equity firms and Amazon and United Healthcare. That's why, one of the reasons why I chose traditional Medicare. So other than that, we are in this campaign. You all are welcome to join us in any way you want. You can go to our website, and that's just PSARA, PSARA.org, and you can sign on to our letters. We would welcome you calling your U.S. senators, Senator Murray and Senator Cantwell, with the message, stop the privatization of Medicare, terminate ACO REACH, and any other way that you all can help us. And Karen, you did a great job. So I don't have a lot more to add.
Oh, well,
And
thank you, Robbie.
we're happy to answer your questions.
Okay, shall we
Oh,
open
wait,
it up to questions?
One correction of Karen.
Good.
She said that 13 doctors signed the PNHP petition. It was
13,000.
13,000.
Oh, I said 13. Oh, my goodness. No, no.
Yeah, right.
Thank you.
Wow, some difference
There
there.
is a difference.
Yes.
Marcia, do
Okay,
you want us to call on people with their hands up, or are you going to do it?
it's
Oh,
just
I'll
fine.
do it.
Oh,
Oh,
thank you.
go ahead.
Okay, good, Adele. Go ahead.
All right.
Peter
Marcia,
Shapiro.
you're the one calling on hands.
Okay, there's Peter.
Peter, you're muted,
There
Peter.
we go. Okay.
There he is.
Everybody will have to unmute themselves when they are going to talk, and then mute yourself back up after. Thanks. Go ahead, Peter.
I'd like to pursue just two little lines of questioning. I don't plan to hold the microphone open for myself for half an hour. The first is, to understand where I am as a consumer. So I'm a member of an HMO, and then I decide to buy, it sounds like it must be a good deal, of Medicare Advantage. When I do that, does it also transfer the supervision of my traditional Medicare that I was on to the Medicare Advantage control?
I'm not sure what you mean by transfer. The Medicare Advantage plans have to meet certain standards that the Center for Medicare Services have created for them. But unfortunately, the oversight by CMS is not very adequate. So there are problems, and we don't want to spend a lot of time talking about Medicare Advantage here, but there have been, for example, if you were in group health received significant fines for upcoding, for saying that their patients had more complex conditions than they actually had. So, but unfortunately, the activity of CMS, they just simply are not staffed up enough to be able to really oversee these giant insurance companies. And the insurance companies believe that it's worth the risk to violate because they don't get caught that often. And if they do, they're making so much money that paying the fine is not that big a deal.
And so the privates are not right now in the middle of the providers, the HMO, and the government money. Am I correct?
No,
No.
Go ahead, Karen.
So are you with Kaiser? Is that? Yeah.
Yes.
Well, Kaiser's a little bit different since they're a nonprofit, but it's still privatized medicine, but it's a little bit better than, say, United Healthcare. We just saw that United Healthcare got sued by the Department of Justice for $2 billion for fraud. And for them, that's a drop in the bucket. So like Robbie said, it's worth the risk to continue their practices and get slapped on the wrist every once in a while.
And so,
But Peter, just real quickly, the difference is with Kaiser, you have a network of providers that you're allowed to go to. And you also will frequently have to have pre-authorization in order to get certain procedures that your primary care physician or your specialist thinks that you need. Under traditional, and that's allowed for Medicare Advantage. In traditional Medicare, there is no limit on the providers you can see. You can go to any provider you want, and there is no prior authorization. So that's two differences. But you pay less for Medicare Advantage than you would under traditional Medicare, because under traditional Medicare, you also have to have, in order to be safe, supplemental insurance, because it is not the kind of full package it should be.
okay, and then the other, briefly, one other line is, what would if I wanted to set up one of these, set up a private corporation, a for-profit corporation, and I want to cash in, I want to get part of that gold that's might going to be available on January 1st. What kind of scrutiny is there given to me, the Shapiro Super Good Medicare management plan,
Well, you would have to probably go out and get some venture capitalists to fund your effort, because setting it up wouldn't be all that easy, you know. You'd have to have some money to do it. And then you'd have to have some, a panel of doctors who would be part of it. I wouldn't advise you try it, Pete.
That was kind of a way of saying what kind of qualifications, what kind of oversight at the get-go does the private company have
To be part of ACO REACH,
yeah.
they have to show that they are involved in providing medical care, or that they have a governance structure that is 75% physicians, and you have to have some history that they would look back at.
Okay.
Honestly, given some of the actors that they are allowing into, that they've given a provisional qualification to become part of the ACO REACH program, you wonder what kind of standards are they setting? Honestly, it's pretty shocking.
Not high.
Okay, that was what I was wondering. Thank you for your patience, everybody.
Okay, Bill, would you like to ask your question?
I will, and this is for both Karen and Bobby. Robbie, I'm sorry to use first names. I've not met either of you. Well, I guess I knew Robbie when he was a law student back in the days, but that's a couple of years ago, Robbie. The question I have, and I'm not an expert in this field, I'm way out of my depth, but I need to get a clearer fix on where the political levers are. Who can stop this sort of thing? Is this something the secretary can do? Does it take an act of Congress? Does it take a judicial decision? But what's the structural arrangement here?
Well, Bill, because it was considered a pilot program, the only one that can stop it is the Health and Human Services Secretary PSARA or President Biden. So that's how it would have to work.
Okay, so if we're going to be lobbying or writing letters or conducting activities to try and change this, they should be directed at Biden and the secretary.
You can also, what we're doing is asking people to sign 2 letters. One goes to, oh, that was weird, to Secretary PSARA and President Biden. And the other letter goes to our congressional delegation. So we're trying to pressure our congressional delegation to have them ask President Biden to stop this program. So
why is Biden's administration supporting it?
Exactly. That's a very good question that we want an answer to as well. We haven't gotten one.
Part of
James, James had a question there. I don't know what happened to James.
James, you're muted.
Oh, James?
You have to unmute.
Can you unmute yourself, James? In the
Jim.
far left corner.
Jim.
There it is.
The cost of setting these organizations up is significant because you've got to have all the computer stuff that will talk to each other. And the research has shown that without physician control, the medical results are not the primary purpose. The purpose is to make money. And I think that that's a distortion of what Medicare was set up to do, to provide health care for senior citizens. And this process allows people with money to make money. And the goal is not health care.
Okay, Bill. Bill
Yes.
Jones.
Karen, did I understand correctly? Did you said people are being swept up into these ACL without their consent?
Absolutely, yes. It does.
Happen?
Well, I can give you an example. So the Polyclinic just got bought out, right? So they're now considered a direct contracting entity. And most likely come January 1st, if we don't stop this, there'll be an ACO REACH entity as well. So they bought it out. So all the doctors, everybody that works there are now employees of this, this entity. And all their patients are now part of a direct contracting or an ACO REACH 2B entity. And often nobody knows about it. I mean, how would you know about it? You could maybe talk to your doctor. They might not even know about it themselves. So it's rather insidious. It's very kind of sneaky in my mind.
Well,
And
I have 2 appointments with polyclinic doctors on Friday, so I'll ask them at that time.
What the standard is that if you see a doctor, your primary care doctor is in an ACO REACH entity. If you see a doctor, you know, more than once who's in the ACO REACH entity, you're going to be in the ACO REACH entity. You might get a letter telling you that you're in it. They're now saying, well, we'll inform people that they've gone into it. But the thing is, if you want to get out of it, you can't see that doctor anymore. You got to go to another doctor. So it's really pretty insidious. And what's more insidious is the fact that so many of us have no idea that it was going on. We picked it up from Physicians for a National Health Program that this was going on. Otherwise, none of us would have known about it. And when I talk to other Medicare beneficiaries, they're like, what? What is happening? How could this be happening to me? So it really is, it is, as Karen said, pretty insidious. And I have no doubt that at the polyclinic, you will be swept into an ACO REACH.
Okay.
Will they get some services that they haven't had, such as vision and other things, or they're going to have to pay for that, I'm sure?
Well, no, Marcia, they're saying that one of the advantages of being in an ACO REACH is you may not, they're not saying vision, dental, and hearing, but they're saying there are certain things that you will get that are not necessarily available in traditional Medicare. So for example, the possibility of home visits. There are a few other things, some transportation, which is really important for people in rural areas, and Medicare ought to provide that in the first place.
Right.
But they're saying there may be some additional benefits that the ACO REACH entity will determine. But no one's saying if you're part of an ACO REACH in traditional Medicare, you're going to get vision, dental, and hearing. I haven't heard that from anyone.
Well, that's what the Medicare Advantage
That's right.
alternatives are saying.
That's right.
I'd like to ask,
Lynn?
very confused. United, from what I understand, United Healthcare is part of this whole profit-making thing. Is that true?
Yes.
How is United Healthcare involved in this? Because
We're having,
I'm asking this because United Healthcare is my supplement Medicare. My former employee at the State Teachers Association has appointed United Healthcare to be the supplement that they give us.
so what you're saying, the supplement's not sufficient?
No, what she's saying, and I understand, Lynn, I have United Healthcare as my supplemental as well.
Oh, okay.
That piece is not impacted within traditional Medicare. What is happening though is that United Healthcare has bought Optum, OPTUM, which in turn bought Polyclinic, the Everett Clinic, and Optum. So if you go to those places and your primary care physician is in those places and you are in traditional Medicare, you will be swept into that ACO REACH entity. but it will not impact your supplemental. You'll still have United Healthcare as your supplemental.
Thank you.
Does that answer your question?
I think so.
Right.
It's complicated.
Okay, Mary Margaret has her hand up.
I'm here and listening avidly, but I can't make the computer camera work. Thank you very much, Karen and Robbie, for your very articulate presentation. And thank you to the Puget Sound Alliance for Retired Americans for agitating with us to help us prevent this ACO REACH from happening. It's really very dismaying. And as you have told us, PNHP, which represents many, many thousands of doctors, has solidly been publicizing this issue. Do we have a clue how our providers here in Seattle are feeling about this issue and whether we can count on them as advocates in this effort?
I'm not sure. If they belong to PNHP, I'm sure they're already advocating, but I really don't know how to answer that.
Well, obviously the polyclinic isn't.
Right.
They've been sued.
Well, we
We're-
know
we're
that
trying
some,
to- Oh, go ahead,
Go
Rob.
ahead. We
No,
know
we're-
that some providers have left the polyclinic as a result of the purchase by Optum of the polyclinic. We know that. I don't know if any of you know Lem Howell, a well-known retired civil rights attorney here in town, but his wife Pat has been going to the polyclinic. And when I spoke to the 37th District Democrats, Lem said, when we talked about this, he said, God, I was wondering why there has been the decline at the polyclinic. Pat, who had been super happy at the polyclinic, is now feeling not happy at all at the polyclinic, which is really too bad. You know, we're
Yeah.
pretty, I'm 78, you know, some of you might be younger than me. And I know that, you know, it's darn hard to have to look at changing our primary care provider at this stage in our lives when so many of them have been going through our lives with us. But, you know, that is the problem, is that the motivation changes. What they are trying to do, and the head of the Center for Medicare and Medicaid Innovation said to us, their goal is to have all traditional Medicare beneficiaries in a accountable care organization by 2030. Every single one. They are looking to eliminate fee for service. They have no data to support that fee for service is increased the cost of Medicare. You know, we asked them for data. They do not have data on that, but there is a liturgy that has been developed that fee for service is bad. And so therefore we have to eliminate it. So we're going to move to what's called a capitated system. And that means that they're trying to get us all into one of these entities. And it's a challenge. We're going to really have to fight hard. And
Well, does Medicaid?
Mary Margaret, it's good to hear your voice, Mary Margaret, even if I can't see you. It's been a long time since I've seen you, and it's good to see you. And I just want to say, we used to be Puget Sound Alliance for Retired Americans, but we're now Puget Sound Advocates for Retirement Action.
Thank you.
Are there any other questions to come?
One of the things that's happened is the
Okay,
majority
Ann,
of physicians.
We'll get you in a minute.
Okay.
Oh, well, when you want to finish that, James, Ann has a question afterward.
The landscape has changed. Most physicians are not independent practitioners any longer. They are employed either by Polyclinic or Swedish Hospital or Virginia Mason, etc. So this complicates the whole thing and makes it more difficult because you're fighting a system as well as trying to find the right doctor.
You know, Jim, that's really an important point that you're making, that we have seen over the course of the last 10 years as the moneymakers the profiteers have figured out there is a lot of money in Medicare expenditure. As Karen said, 1.8 trillion by 2028. The insurance industry has been working to figure out how they can get into the traditional Medicare system. Now, what they have come up with is a process called risk assessment. And that's what Medicare, what insurance companies do, is they assess risk and they determine based on risk who they want to insure on and what the level of risk is. They've now thoroughly convinced a number of the policymakers that we have to move away from fee-for-service and into capitated based on risk assessment, which gives them the opportunity to make huge money. And the movement of private capital into healthcare in general and Medicare in particular is frightening. It's genuinely frightening. I wrote an article for this upcoming issue of our newsletter. We put out I must say, a high quality newsletter every month. And we like to call it the best non-award winning newsletter in the country.
It is great.
My article this time is going to talk about it was based on an article in the New Yorker magazine, and it talks about a nursing home in Richmond, Virginia, that was run by the Sisters of Poverty. And because of the huge reduction in the number of sisters in this country and their principle that they were going to live in the nursing homes or the retirement homes that they own, they sold off this nursing home to a private equity company. And the level of deterioration of care at that retirement home in Richmond, Virginia was absolutely frightening. And I quote in the article a study that was done by forget where the professor is from, but he's known in the medical policy world, that the retirement places that are owned by private equity have a 10% higher mortality rate than those that are owned by nonprofits. And we're facing that throughout the medical system. And we're going to have to battle. We're going to have to battle over it. It's not exactly how I anticipated living retirement, but we're going to have to battle over this and try and stop it. Sorry, Anne had it.
Yes, Anne, do you want to get yours in now?
I think our supplemental is Uniform, which is a government employee supplemental program and fairly large. And has anybody heard from them about how they see it?
You want to talk about the struggle we're in with that one, Karen?
Which one is
No, with Uniform.
Yes, that's the classic Medicare option.
Right.
Yes, and we were alerted by the Retired Public Employees Council that the PEBB, the Public Employee Benefit Board, was going to be asked to eliminate the classic Medicare option. And we have been there's a coalition that has been formed to fight this effort to try and eliminate the classic Medicare option. Fortunately, a number of us had contacts into the governor's office and with our legislators, and they had planned to eliminate the classic Medicare option in January of 2023 for public employees. We were able to stop that, and we were able to set in motion a process where they have to be in touch with the public employees who are part of the classic Medicare program. And we're going to be having some listening sessions with them and public testimony on the part of public employees that are in the classic Medicare option with PEBB. And our goal is not only to try and stop any idea of eliminating the classic Medicare program, but in fact to expand it. So you really should, I don't know if you're a member of Retired Public Employee Council, RPEC, but if you want to be in touch with this, you should either be a member with them, or if you're a member with us, we're going to keep you in touch because we're heavily involved in stopping the healthcare authority from eliminating the classic Medicare option. And actually what they decided to do was move all of you that are in the classic Medicare option into the United Healthcare option. That's what they were talking about doing. And we put a stop to it.
How does Medicare for All fit into this?
Well,
that's a good question. I would say that if this program goes forward, it won't be Medicare for all, it'll be Medicare Advantage for all. And any hope of Medicare for all is gone if we don't stop this now.
Once the private equity companies and the insurance companies get their hooks into public traditional Medicare and have a financial investment and interest in it, you know, we believe that the hope of having a public Medicare for all program in this country, it's gone. So that's why we're fighting so darn hard and spending so much money to try.
Don't they already have their hooks in it?
Well,
Don't they already have it? Oh, aren't they already involved?
That's why we're trying to save traditional Medicare and hold off, you know, the ACO REACH program. Part of it is certainly privatized through Medicare Advantage.
Medicare Advantage obviously is privatized, Marcia, but there's also some programs within traditional Medicare that unfortunately have been privatized, but they're very small.
I see.
And what the ACO REACH program would do would be to expand it enormously.
Okay.
And that's what we're trying to stop.
That's what we have to work on.
That's right.
And Medicare Advantage will come later.
Well, we're going to have to take them on for sure, because people, you know, when you see the rate of prior authorizations that are, you know, incorrectly being denied, and that was not what we're saying. That was the Inspector General of Health and Human Services that did a study and found that. And we already know that they are making huge amount of bucks, and part of that is by upcoding. We're going to have to go after Medicare Advantage, but that's a tough one because there are a number of people that have Medicare Advantage plans that are pretty happy with them. They don't get unhappy with them until they get complicated conditions and they start running into some of the restrictions on care. And we had that with one of our members who he wrote a piece in the Retiree Advocate, our newsletter. He's a former veterinarian and a professor of veterinary medicine. And he was in a Medicare Advantage program with Primera. And he got a growth on his ear. And his primary doctor, did you read that? You know, and that turned into something very serious because of the whole issue of prior authorization. And the
delay of service.
Delay of service.
Right, exactly. So that's the kind of thing that we're worried about. And we don't have to worry about that in traditional Medicare now. If your primary care doctor says you need to go see a specialist on this, there's no one saying, wait a second, we have to authorize that. That doesn't happen. And this is going to be a real attack on that.
I see.
Okay, shall we say two more questions and that's it? Because I think we better.
The
Okay,
time is getting short.
you want to? Go ahead. Well, if we have no more questions just now,
I do.
Wait, Peter
you
has
do.
his hand.
oh,
Okay, so but since we got into the area of control of decision-making, is there a good group that is keeping an eye on contributions to congressional campaigns from these private entities that will have a lot of money at stake and a lot of money to spend to buy their votes?
I know there are organizations that are looking at the contributions. We're not one of them, Peter. We just know they're spending their money on politicians.
Well, okay. Why not?
Any other questions? Well, as you
okay.
know, yeah.
Well, I want definitely to thank both of you and your PSARA organization for being on this and buying the ads for the newspapers and spreading the word. We'll be showing this recording both Monday for the League of Women Voters meeting, and the following evening it will be on HHTV, and the entire house will be able to see it. So thank you for the questions that have come up. Thank you for the evidence that you've shared.
It's wonderful.
And I just want to close by saying we would welcome you becoming members of, if you're not a member yet, of Puget Sound Advocates for Retirement Action. As I said, it's only $20 a year. And for that $20 a year, you get the best non-award winning newsletter in the country. And
I agree.
with a lot of information about it that you might find helpful. Thank you for inviting us to be here. We're very appreciative. Karen, you want to close?
Thank you so much. Yes, we really appreciate it. And do consider signing on to our letters and encouraging your friends and family and everybody you know to take some action to prevent this travesty from happening. So thank you. We'll be out there. We'll be advocating. We'll be glad to answer any follow-up questions for any other members that may see this, Marcia and Adele.
Okay.
So please feel free to reach out to us if you have any thoughts, concerns, or if people want to get to be more active, we'll be glad to help them that way too. So feel free to contact us anytime.
I just want to
Thank
say
you
Mark
very much.
McDermott got us involved in the newsletter. It was great.
Oh, wonderful. That's
Okay, thank you very much.
And Bill Anderson, good to see you.
Bye-bye. Thank you.
Thanks.
Everybody.